A very good afternoon. Thank you so much, sir, for your kind words. But I always have wondered that if I have half the enthusiasm that you have, then it makes my day. Thank you, Dr. Atul, sir, and to the organizers of MAPICON for having me here and talking on a talk which is very dear to my heart and concerns about a woman's cardiovascular health. So cardiovascular disease in women is really very important because there's a lot of disparity in care. The average lifetime risk of developing cardiovascular disease in around a 50 years old woman is 40%, and it increases with more and more risk factors that a woman has. It is actually an undertreated and an under-recognized problem because of the disparities which occur. There are disparities in how we are testing our women, how we are treating our women, and of course the outcomes that they have. So when we talk of men and women, and we look at the risk factors that we have, and we talk of prevention, prevention can be primary prevention or it can be secondary prevention. In primary prevention, of course, we are aware of some risk factors which men as well as women have: age, sex, diabetes, hypertension, and so on. And then there are some risk factors which we look, which are cardiovascular risk factors, which are more predictive of worse outcomes in women. So they are smoking, diabetes, and psychosocial factors. If a woman is a diabetic, she has risk factors which are multifold in her to develop cardiovascular disease. If a woman is smoking, again, she's multifold at risk of developing a cardiac problem. If she has psychosocial problems, again, her risk increases. And besides these risk factors which are more predictive of worse outcomes in women, there are some risk factors which occur just in women. And those risk factors, we all are aware, could be some contraception use, hypertension, gestational diabetes, eclampsia, preeclampsia, pregnancy-induced hypertension, and so on. So women are entirely different. They have got some female-specific cardiovascular risk factors, like pregnancy-related risk factors, which we just now talked, which we hardly bother. A woman gets pregnant, she has hypertension, and then she forgets about it, rearing babies after around when she has an early onset of a cardiovascular event. So pregnancy-induced hypertension, eclampsia, preeclampsia, maternoplacental syndromes, stillbirths, abortions, everything contributes to cardiovascular risk in a woman. Then there are some female predominant cardiovascular risk factors, and those female predominant cardiovascular risk factors are autoimmune diseases like SLE, rheumatoid arthritis, scleroderma, breast cancer associated with chemotherapy, and so many other things. And then these were the risk factors. There are some conditions which are female-specific cardiovascular conditions which occur just in women, like we know is peripartum cardiomyopathy, and then female predominant cardiovascular conditions like Takotsubo cardiomyopathy, myocardial infarction with normal coronary arteries, endothelial dysfunction, microvascular dysfunction, SCAD, and so on. So with this understanding, we proceed further and realize that women may have less obstructive coronary artery disease, and even with this less obstructive coronary artery disease, they have much higher cardiac mortality. So why could that be? That could be because of some differences which are there in their coronary arteries, which are smaller, which have abnormal coronary reactivity, or the ones which produce more of superficial plaque erosions. They have more microvascular dysfunction, more distal embolization, and of course, we cannot forget the hormonal changes, increased arterial stiffness, which comes with the menopause. So this is how it is. If we look at the coronary artery of a woman and a man, the coronary artery in a woman would be smaller, and it would be, subtending a smaller area of myocardium as compared to that in a man when it is going to subtend a larger area of myocardium. So with the same account of lesion that a woman would have, she would have a higher FFR. That means that her fractional flow reserve would be higher across a coronary artery as compared to man. We understand that when FFR is high, that woman may not need revascularization. So with same degree of occlusion and similar coronary artery, the way a man and a woman would behave would be different, with higher FFRs which are recorded in women. Now let us look at plaque erosions. Women have high incidence of plaque erosions, less of plaque ruptures, which we know are associated with acute coronary syndromes. The plaques in women are different, less calcified, less obstructive, a diffusely diseased coronary artery, and outward remodeling which occurs. Microvascular dysfunction, more common. Higher coronary blood flow reserve, flow at rest, and coronary flow reserves are lower. So when all this is different, ladies and gentlemen, don't we think that women would need a different kind of imaging also? Probably yes. So women also have worse outcomes. If a woman infarcts, her outcome would be worse than a man. Why? More comorbid factors, elderly age, more bias, biological response is different to antiplatelets. She would be attended by a physician late. She would have atypical symptoms. When attended, she would probably get less thrombolytics. She would get less angioplasties, less aggressive management, and inferior secondary prevention. So primary prevention as well as secondary prevention as well as rehabilitation has been proven by enough evidence to be different in women who are getting less utilization of cardiac resources. Their first medical contact to device time is different. They are referred less for revascularization. They get less rehabilitation and of course less evidence-based treatment. So, having said that, the prevention is undermined whether it is primary or secondary. Also the risk assessment tools. We have the similar risk assessment. So the risk factors are different, but the risk assessment tools are same for men and women. So if we look at these risk assessment tools which are traditional, they undermine women, whether it is pooled cohort equation or whether it is Reynolds risk score or the score 2, they all underestimate the risk in any given woman, arising the need for probably more preventive tools in women, which could be an efficient imaging. So if we talk of imaging in women, what comes to our mind for prevention, for primary prevention? Somebody would say coronary artery calcium. You're right, that is how we start. So let us see how guidelines place it. Coronary artery calcium has been placed somewhere in the ACC guidelines for guiding the therapy. A CAC score, you have a woman, you suspect risk, send her to get her coronary calcium score without giving her the dye for CT angio. A coronary calcium score of 0 says very low risk for the next 5 years, and we can probably defer any statin or preventive therapy in this woman. A statin is recommended in a woman for primary prevention if she is having a non-zero calcium score, a non-zero CAC. If her recommended score is more than 100 or more than 75 percentile for age and sex, of course it's recommended to treat her with statins. Intensive therapy with statins is recommended if CAC score is more than 300, and aspirin in women for primary prevention may be considered once you have a coronary calcium score of more than 100. So it's a critical tool for assessing women. And how is it in comparison to men? Are men also to be treated in the same way? Let's see. So if we have at any given age, women would have a lower prevalence of calcium which is present in their coronary arteries, and they would have lower scores. A woman's score would often be comparable to a man who is 10 years younger than her. However, whenever coronary artery calcium is present, more than 0 in a woman, this predicts a much higher adverse event of coronary event in a woman as compared to man. So a lower burden of calcium, however, a greater risk in women. So this is how this cartoon describes. A woman would have a smaller vessel, lower plaque volume, less necrotic core, lower calcification, a lower calcium score. However, with this presence of lower calcium score, she would be placed with almost an equivalent or more adverse risk than a man, and would probably have ischemia without the presence of obstruction in her coronary arteries. So no obstruction, however, would mean adverse coronary events. So we talked of coronary artery calcium, and now CT coronary angiography for primary prevention minded. We are talking of a woman who is not symptomatic, and we are assessing her for primary prevention. So there was a trial called as a PROMISE trial which was conducted, and it was found that women who have abnormal CT coronary angiography had higher rates of major adverse cardiac events as compared to any woman who would have an abnormal stress echo or an abnormal TMT, suggesting that probably CT coronary angiography has a better prognostic value. So they did this trial, and then they followed it up further also for 5 years, and it was found that when compared, and when we were just giving a standard care and using traditional risk scores and treating our women, vis-a-vis when we were using CT coronary angio for primary prevention and treating them with statins, it was found that women who were treated with standard care plus coronary CT coronary angiography, the death from coronary artery disease, the primary endpoint, was much lower in the women who had CT coronary angio based treatment. So coronary CT angiography in women detects more of non-obstructive coronary artery disease, predicts a higher risk with a hazard ratio of maybe 1.36 for mortality for women who are not detected with coronary artery disease. And CT coronary angio not just looks at the lesion, it also defines the high risk lesions in women, which can be identified on the basis of outward modeling, some napkin ring lesion appearances which are picked up in the CT coronary angiogram. So we talked of coronary artery calcium, we talked of CT coronary angiography. Now the next thing which we usually do, we do and look at the carotid intermedial medial thickness and the plaques. So plaques are known to prove more of association with the atherosclerotic burden in women, and their presence is more predictive of cardiovascular events in future as compared to carotid intermedial thickness. However, the new thing which is emerging in this era is not just to go and look at the intermedial medial thickness of the carotid artery, but to look at the progression which is occurring in this IMT. So it is found that if the IMT progression is higher with coming times, that could be a predictor of coronary events. Now talking of something which we cannot escape when we talk of imaging in women, and that is INOCA. What is INOCA? We know that INOCA is presence of myocardial ischemia without any significant epicardial coronary artery disease. So INOCA is of several endotypes, but the first one and the commonest one which occurs in most of the women whom we are labeling at present as functional and psychiatric disorders, that is probably coronary microvascular dysfunction which they have. A woman comes to us, we do a treadmill test, the TMT is positive, she goes for an angiogram is normal, everyone in the family tells her you are, some psycho, you are stressed out or whatever. However, that doesn't end, because coronary microvascular dysfunction is a very important emerging diagnosis where treatment can act. So traditional risk scores and traditional thoughts are undermining what is ischemia with non-obstructive coronary artery disease. This is what we think coronary artery disease is, right? This red cartoon, obstructive coronary artery disease, lesions in angiogram. However, CAD is much more beyond. CAD is also diffuse, non-obstructive, maybe 20 to 30 degree plaque. CAD is also coronary microvascular disease. CAD is also epicardial spasm, and coronary artery disease is ischemia, a documented ischemia, maybe on a treadmill test, maybe on any other functional test with a non-obstructive presence in an angiogram. So these are the types of INOCA, these are the types of ischemia with non-obstructive coronary artery, and the first one, the microvascular angina, is what occurs commonly in women. Look at this cartoon. So if a woman has come to you with a cardiac chest pain, just 10% times it would be non-cardiac. Beat it, 90% of the times, even if you are not able to find a coronary lesion, she would be having some coronary abnormality, and the commonest of that in 50% of the cases would be microvascular dysfunction, that is microvascular angina. It could be vasospastic or a mix of both, either ways. And it is important because women who are having microvascular dysfunction and myocardial flow, abnormalities, they have a prognosis which is really bad and entirely different from men. And if we look at this is the obstructive CAD and the risk which is associated, clinical risk with obstructive CAD. The non-obstructive CAD in presence of microvascular dysfunction has almost similar risk. So if it has similar risk, it obviously needs similar degree of attention and management, especially in women who are having it. So how to identify it? A cardiac PET, a cardiac MRI. A cardiac PET is the gold standard, and it is said that a myocardial blood flow rate of less than 2 is abnormal. Women with very reduced, less than 1.6, are at maximal chances of having adverse cardiac events, and they need to be treated. But treated with what? So, there was a group which is called as COVADIS, Coronary Vasomotion Disorders International Study Group. They said that how to identify. So, this would be a woman who would come to you with symptoms of myocardial ischemia, maybe chest pain, exertional dyspnea, some angina equivalent. Then her angiogram would be normal. There would be absence of obstructive coronary artery disease. However, she would have an objective evidence of myocardial ischemia. So what is that objective? A positive TMT, a positive stress echo, a positive stress thallium or a SPECT. And beyond that, if you subject her to the assessment of myocardial blood flow in a PET or a SPECT, there would be evidence of reduced myocardial blood flow rate. That means evidence of impaired coronary microvascular function. So the CORE-MICA trial says identify the woman, find out the cause and treat it. Find out the endotype. If it is coronary microvascular dysfunction, your modality of treatment would be different. Maybe you would like to treat her with calcium channel blockers and drugs like nicorandil, or maybe diltiazem, or maybe nitrates, which would act at the level of endothelium and give functional as well as objective relief to the patient. Vis-a-vis, if you have an obstructive disease, of course you're going to give aspirin, statins, beta blockers, and the stuff which is the routine. Having said that, we now also have an advanced imaging system in which there is a hybrid PET-CT. So what is this hybrid PET-CT? PET identifying coronary microvascular dysfunction, and a CT or a CT coronary angiogram picking up any obstructive lesion. So cardiac PET, cardiac MR, coronary microvascular dysfunction, and so on, and important care needed for patients for INOCA, because this personalized care is what a patient of microvascular dysfunction needs, which we not at all think in our OPDs. Woman comes, angio normal, go. So a lot of evidence gap is there. There are trials which are coming up to address it. For example, the CORCUL trial, the Robinska trial. These are the trials for primary prevention. They are studying, studying the role of CORCUL trial, for instance. This studies the coronary artery calcium score and compares it to the routine screening rules which we are using for primary prevention. And it was found that superior statin adherence is found in the patients who are studied with coronary calcium score arm. It is also found that if we are using these trials, probably we will have less patients who turn out to be very high risk, and we are going to give tailored treatment only to at-risk patients, would save our resources as well. So the future of imaging probably talks of CCTA, talks of cardiac PET, talks of cardiac MRI. There are trials which are ongoing. This is a trial, Scott Hart 2 trial. This is ongoing. A sub-study, a part of it, has already said that a coronary CT angiogram for primary prevention, mind it, a patient who is not symptomatic, we are just doing a risk assessment, was associated with modest improvements in healthier lifestyle. This is the cartoon of that trial, which is ultimately going to study the outcomes, the primary as well as secondary outcomes in these patients. So these are the imaging tools: a coronary CT angiogram in setting of stable pain, a calcium score for predicting CV mortality, a cardiac MRI or PET, and these are the sensitivities and specificities of these tests, which are almost equivalent in men and women. This cartoon is big. It would take a day to talk everything. However, all these investigations have their pros and cons. Of course, cost is a big limiting factor for us in treating these patients. It's difficult to get an angiogram for our patients at times. So what to say? However, understanding the disease and targeting it in the right way would almost always remain very important. Studies like Women's Health Wake Up Trial are on to study the ultrasonography and study the endothelial dysfunction, not just in the carotid but in the iliofemorals and everywhere. So before I end, this is a patient, an example, a 40 years old lady who walks into your OPD and she says that she's had some chest pain. You send her for an angiography. The angiography is normal. So you said, okay, your angiography is normal, but I still want to see that if there is any functional ischemia, you send her for a routine SPECT test, you know, a stress thallium or a stress echo, that also turns out to be normal. You think that probably all is fine, but the story actually doesn't end there, and that's what I'm trying to say. You have to probably send this patient for a specialized cardiac PET where myocardial blood flow should be assessed. And if you look at down here, normal coronaries, the cartoons are showing good bright images suggestive of no ischemia which is documented. But if you look at this one figure out here, 1.3, so 1.3 is less than that 1.6 myocardial blood flow rate which I mentioned. So the myocardial blood flow rate is pretty low. So this patient is having chances of having adverse coronary events and should be treated like, you know, you're treating your diabetics and, you know, considering them as high risk patients. So to conclude, we need to go beyond the usual traditional scores that we have. We need to probably consider coronary artery calcium, which we already are doing, as a stratifier. We can use CT coronary angio for phenotyping our patients. We need to address the coronary microvascular dysfunction in our patients. However, the future of cardiovascular prevention for a woman isn't in just better algorithms. It is in our ability to apply these advanced imaging tools and the knowledge that we have to a truly sex-specific, targeted and effective preventive strategy. Because this is one slide which I really loved when I was going through some of the literature. It is of 2017. However, in words of Angela Maas, ischemic heart disease in women is not about religion. Cardiology for women is not a religion for cardiofeminists, as some of us call them, but it is an evolving scientific field with evidence-based data that needs to be implemented in clinical practice. A culture shift is needed in cardiology. Thank you very much.